stromal lenticle addition keratoplasty, SLAK. Okay, you know that a potential major advantages that we have with SMILE or relics with patients is that don't evaporate the tissue, but we remove this tissue, and remove tissue that is still vital. Is it very important? I don't know why this doesn't work. I prefer so, no, sorry. Okay, we know that it's very important. Why? Because it's possible that we have two advantages. The first is the cryopreservation that is possible with this still vital tissue, and secondly, that it's possible to reimplantation of this lenticle. You can see that the question is why not? It's not possible to perform this surgery in corneal reshaping in ectasia or particular keratoconus or central keratoconus, obviously without glaucoma. We know that here it's possible in our aim is to obtain contemporary two possibilities. The thickening first, because here we have two problems, that is the thinning in center first and the increase of curvature. I must eliminate the curvature and I must perform the thickening. With theoretically, you can see that we have two possibilities. The thickness law to obtain thickening, and the other is the arc shortening effect to obtain flattening. This contemporary, because it's correct to obtain these two possibilities, contemporary. At the right of this situation, we decide to perform and to build a negative meniscus lenticle. You can see here that this meniscus has in different size thicknesses. Here in center to obtain increase of thickening, and this in periphery with the shoulder to obtain the flattening. First, we published it 2 years ago here in the iBank High. This is an iBank model. You can see here that we insert, that we prepare before this lenticle, that we insert into the pocket that we perform in iBank High, normal iBank High, with this inserter that we design it. And here you can see that we insert into the pocket with our femtolaser 500, and then the stretching like makeover, and this is the results that we obtain. You can see that corneal profile, curvature, and thickness changed after lenticle implantation. You can see here in this OCT, before and after. You can see that when we compare the corneal map, the tomography, before and after, and OCT, you can see the difference in iBank High. Then we prepared the Keratoconus model example that we performed this and built thanks to excimer laser. And then in this model, we put the lenticle, and you can see the difference that we have before and after. At the light of this situation, this change, we decide to perform this surgery in humans. And you can see here, this is in Keratoconus model before and after, and in human, we call this technique SLAK, stromal lenticle addition keratoplasty, for the treatment of advanced keratoconus. This is a preliminary study that we published in this here in Journal Refractive Surgery. You can see that he will prepare the lenticle before, and then we insert this lenticle. We prepared the pocket with the femtolaser, and then text to inserter, we insert this lenticle in the pocket, and then perform the stretching. It's more difficult than in iBank Eye, because obviously here we have the IPU, intraocular pressure and the pressure of vitreous. You can see that this is real-time live the surgery, and here the SLAK, stromal lenticle addition keratoplasty, before and after 1 week. This is in and now is the change in anterior corneal topographical. You can see after the SLAK, before and after. This is in OCT changed and pachymetry map. And this is our the results. 6-month visual refractive outcome. You can see the outcome, but it's very important the stability over time that we obtain with this technique. These are the results I repeat after 6 months, and this is the stability that we obtain. This is the astigmatism, the vector analysis of refractive astigmatism before and after. All these eye were prepared for the dark the day after. And we performed this technique in these patients, this eye. You can see an example, male, 30 years old, Keratoconus stage 4 with central apex. This is the visual acuity with -7 sphere and 8 of cylinder before. Then 1 month, 20/40, 3 and 2 of cylinder, and after 3 months, 20/30, 2 and 2.5 cylinder. This is the difference between the SLAK that we perform and the ICR corneal ring. The difference is that here we have only the flattering, and here we have thickening and flattering contemporary. These are the wavefront aberration difference after SLAK. You can see that we have the reduction, particularly of the coma, that is possible to measure, and you can see here the number under the slide. After 1 month, 1 year, you can see the result here in red field. It's very stable over time, this surgery. And this is the in vivo confocal microscopy of implanted lenticle. You can see 1 week after, 6 months after, in anterior lenticle interface, lenticle that we implanted at the posterior lenticle interface. You can see here is not present activated keratocyte, is no presence debris, no dendritic cells, no presence of fibrosis. You can see that is very, very good. Also the interface, and this is the future that we are working with this international group with John Meda, Kochner, Dua, and Alio. We are perform the next step, that is the cellularization and the lenticle bioengineering, because it's very important the deceleration of this lenticle, because is our idea to prepare a transplantable bioscaffold, and after the implantation to wait the repopulation with the keratocytes of the patients. You can see the first slide that we prepared in my university before and after this, and this is in the lenticle morphology in transmission electron microscopy in TEM, in control and in treated. You can see that here disappeared all the keratocytes. In conclusion, we know that this SLAK, this negative meniscus, appear a feasible technique for reshaping the cornea in keratoconus in 4 stages. And we obtain a technique, a flattening, contemporary, and it is very important to reduce the ectasia and to have the flattening of the cornea and reduce the curvature of the cornea. Further studies obviously are needed to assess the ideal profiles for achieving the best corneal remodeling in different ectasia. The future now is also the customized lenticle in keratoconus that are not central keratoconus, but are keratoconus like pellucida or other ectasia that is possible to find, and tissue bioengineering can further optimize the procedure. Thanks a lot for the attention.